Can you all hear me?
The mic's not on.
The mic's not on.
All right, there, we'll go with that. So thanks so much for being here. It's the end of the first day of this conference. It's been a wonderful day. And I am going to spend some time talking about nominal group technique, which is a key tool in a certain kind of implementation science approach. You probably heard a little bit about it earlier today. We're also going to do nominal group technique together. So you're going to have to hear me out for a little bit, and then we're going to focus on the question that Ryan just introduced. So nominal group technique was developed by social psychologists and engineers back in the day. One of them is Dr. David Gustafson, who's also a founding person in Niatex itself. So Dr. Gustafson is very close to these tools. One of the benefits of Niatex, and tomorrow morning I'll actually be giving a talk about Niatex itself. Niatex originally stood for the Network for the Improvement of Addiction Treatment. It is an implementation approach to improving the practice, that dreaded 17-year gap that we heard about this morning between knowledge and actual implementation. One of the benefits of Niatex is it's a way to involve people, staff, persons who might be patients, members of the community, and to improve morale and to move toward creating new opportunities together. So Niatex is predicated on a set of ideas about the co-production of knowledge, and so is nominal group technique. So I won't spend a lot of time on co-production because I want to talk about it a little bit tomorrow. But basically the co-production of knowledge is the creation of knowledge or data through a shared process. So a shared research process, guided sets of ideas and conversations that involves different levels and backgrounds of people. So it's really a major piece of the translational process, right? So it's co-production of knowledge. And one of the key principles of Niatex is to understand and involve the customer. So I find in healthcare, we don't do this very often, right? Maybe we're getting better at it, but it's very rare that any kind of medical, clinical intervention is essentially built on first asking the person, what do you want? Right? What do you want? And we assume a lot of things. I was talking to Dr. Ramond about this earlier. We assume a lot of things about what people should want, because we know what actually works in some ways, right? But not everybody wants what we know, right? So there's a lot of, I think there's a lot of space between that, that idea that people who are, that we call patients, are not to be on the receiving end, if you will, of our knowledge, but rather should be part of the co-production of knowledge. So Niatex sees change as a regular and ongoing element of work. How do you determine what to change? So where's the baseline set of ideas come from? How do you find new ideas and generate baseline data? One important way is through nominal group technique. So as you can see, this is a 1975 reference. Senior author Dr. Dave Gustafson, who went on to found a major engineering center oriented toward producing new results in healthcare practice at the University of Wisconsin-Madison. And Dr. Dave is actually a good friend of mine and a real mentor. So nominal group technique is designed to promote group participation in the decision-making process. It can be used by groups to reach consensus, right, on the identification of key problems or on the development of solutions that can be tested using rapid cycle changes. Again, more about that tomorrow. So the basic steps in conducting nominal group technique, there are 4 basic steps. You can do this with anyone. You can do, if you're in a big family, you can do it with your family to figure out like where you want to go on vacation, right? Nominal group technique is a very even-handed a technique that can be employed very rapidly. We could do a nominal group technique, and we will, in 20 minutes that will involve everyone in this room, creating some actual opportunity and input into the question that we ask. So first and foremost is silent idea generation. Step 2 is round robin recording of ideas. Step 3 is serial discussion of ideas. And step 4 is final voting. And I'll walk through each of those steps. So silent idea generation. First, we want to clearly present the question. So you want to ask a question in a way that you're attempting to elicit objective responses from people. Now, you will get some subjective responses, that's okay, but the idea is to ask a question that's intended to elicit objective responses. It's important to think carefully about how you phrase and frame the question. First and foremost, just asking a group of people a question is actually a signal that you care about the answer. Right? So when you put people in a room together and you ask them all the same question, you're giving them the message that you care about what they think. Right? So there's more than one thing going on here, right? That's a social psychology technique around building group cohesion. Not only does it build group cohesion to do such a thing, it builds a kind of confidence in the potential solution. People feel as if they've contributed. So you can literally do nominal group technique with 350 people in an auditorium in an hour and come up with a lovely list of people's ideas that are actionable, right? So it's important to think carefully about how you phrase the question and how you frame the question. Remember, we're looking for co-production of knowledge. So think about the words you use, think about what you're really asking people to do. The leader will then encourage participants to silently and independently write ideas in brief phrases. So people take a pencil, they just write down what comes into their heads. The benefits of silent idea generation include adequate time for thinking and reflection through recall. I mean, it never gets quiet in rooms where you're trying to run a focus group, right? So this is a way of really asking people to be calm and quiet and to see what actually floats up in their heads. It promotes social facilitation. We can see each other participating. And so again, back to that idea that people are vested in what the potential outcome might be. It avoids interruption to do silent idea generation, undue focus on a single person or an idea, people competing with each other, trying to get their point across, right? Everybody has an equal opportunity to really generate ideas. And it also promotes focus. We work with a person, Dr. Farnham and myself have worked with a person who says, let this silent idea generation go on a little longer than you want it to. Because maybe that's when the creative thoughts really rise to the top, or people are like, oh, what's coming next, right? It builds a little bit of potential creativity and maybe a little bit of tension. Step number 2, round recording of ideas. So we will do this together, and you'll see what I mean by this, but each person offers one thought, comment, or answer. Right? So everybody offers one thought at a time, without explanation, simply a thought, right? Not a lot of discussion. One person, one idea, move to the next person, elicit another idea. The next person offers his or her thought, comment, or answer, one person at a time. Again, what this does is it is a way of having equal participation among all the persons in the room who are doing nominal group technique without a single person kind of dominating, which can happen. And it also allows people to hear each other. So if you have one person at a time, the other people, by definition, are not talking. They hear what the other person has actually said. Right? So there's a really good reasons to have round-robin recording of ideas. Promotes equal participation. It increases problem-mindedness and the ability to deal with a large number of ideas. So the more you do this, the more you hear from people, the more they hear from each other, the more ideas are actually floating out there, right? So it is a production process of a large number of ideas coming forward in a short amount of time. It separates the ideas from the person. when you're doing one at a time and the next person goes and the next person goes, it's not this person's idea, it's just an idea that came up in response to the question. Allows for the tolerance of conflicting ideas, again, because we're not having a lot of discussion about each of these things. We're simply stating an idea and moving on to the next person. You know, even if you disagree with that person, you kind of mull it over. And you think to yourself, I wonder why they think that. Or so it increases tolerance for different perspectives and different ideas. It encourages hitchhiking on ideas, which is the process that really, when somebody says something, then you say to yourself, oh yeah, that reminds me of this, right? So you're hitchhiking on other people's ideas. There's no kind of pride of ownership or authorship here. It's just a group process. And it provides a written record of the ideas. So the other thing that I think is, when you go to the psychology universe, right, these things produce, nominal group techniques produce these big lists of ideas. If you're in a room with a bunch of people, you take a piece of tape, you stick this to the wall, these are work products. You can see what people have actually done, how they're participating, right? So you can have these work products just hanging around the wall, and again, it is it's a way for people to participate in solution making. Step 3 is serial discussion of the ideas, right? So as the group leader, you will ask people to take each idea one at a time, make sure you got the words correct from that person's perspective, see if they have anything else they want to offer. They discuss and clarify the idea prior to voting. The benefits of this step that it avoids unduly focusing on any one idea or subset of ideas. So again, we just go down the list and say, you know, is everyone clear what so-and-so meant by this? Are you clear about do we want to add something to this? This is also potentially an opportunity for people to say, well, those two ideas seem like the same thing to me. And if that's in fact the case, you can rule one out, right? Or you can combine them in a single place so that you can combine like ideas. And it eliminates misunderstanding. I've been doing this quite a lot in Central Asia and Ukraine over the last few years, and of course a lot of it is happening in other languages other than English. So I'm hearing the interpreter, I might be writing down an idea, I may not in fact have it correct at all. So there's that opportunity to do some clarifying there when you're working with people in this step. And step 4, so again, really straightforward steps, many options on how to vote, but everyone gets to vote. We give each person 3, 4, or 5 votes. I like 3. Sometimes I like 5. I really like odd numbers, right? And the way the votes work is that you can put all of your votes on a single idea. Right? This is the most compelling thing I heard today. I'm going to put all 3 of my votes over here. You can spread them out amongst 3 ideas, or you can do 2 and 1. Right, so if you have 10 people, then at the end of your nominal group technique, then you have 30 votes. Right, so that's what you're really looking for. Just a couple of thoughts about that. Make sure when you're doing a nominal group technique that you want to use for research purposes, that you know who's in the room. So really basic kind of stuff, because they become participants, right? So in the healthcare universe, I like to know role. What's your role? Are you an administrator? Are you a physician? Are you a nurse? You know, what's your role in the process? Gender and approximate time in the field, that kind of thing. Just so you can characterize a bit about what you're doing. You want to make sure that on the top of your sheet, you write down the question and the date. Right? Sometimes I'll write down 12 participants, you know, 7 men, 5 women, and healthcare, whatever. So it's all on a single piece of paper. Now, back in the day, we used to carry those pieces of paper around, but now you can just take a picture with your phone and you've got it, right? That's your work product. So 4 steps to nominal group technique, right? We're going to do silent idea generation, round-robin recording of ideas, serial discussion of ideas, final voting. The end goal here is to identify barriers or facilitators, right? So you're either going to be looking for what gets in the way of something or how we can solve an issue. look for objective sorts of thoughts there and phrasing of the question. At the end, we compile the vote totals and report it all out to the participants, the final voting tallies. So the last point I really want to make before we get right down to doing this together is, the question that on the table for today is what gets in the way of screening for cognitive impairment in older people with HIV? Right, so we know that older adults develop cognitive impairments, but people who have HIV, even people who have achieved viral suppression, they have a higher rate of developing cognitive impairment, right, which is not well understood yet. But it's also not well, our response is not well organized. So what gets in the way of screening for cognitive impairment in older people with HIV is the question, right? Want to add to that, Sheila? Okay. Thanks, because this is not my particular area, and I was assigned to this question, and I'm good with that, because this is a process question. But you always want to ask yourself, what's the evidence base for this question? Why are you asking people this? Right? Make sure you tell them at least a bit about it. So we would say, I might say, what gets in the way of enrolling a person in a treatment program with medicine for opioid use disorder? What are the barriers? Right? There's a lot of, so you can always find a way to ask the question, but people need to understand what the gap actually is. Why is this question important? Why do we care about this? Right? So clearly connect the question to an implementation challenge. We have this evidence that's out there, that we have more people who are older adults living with HIV, many of whom have achieved viral suppression. They're still developing cognitive impairments at higher rates than other older adults, right? What gets in the way of screening for that? All right, so questions before we do this together? Okay, so we were going to have this kind of be like, a microscope that these people sitting at table 5 were going to do the NGT and everyone else was going to watch. That's partly going to be true. I understood that you all volunteered for this. I saw a list and I was told that you did. But we could have a couple more people at this table, and it would be great if the rest of you could divide yourselves into tables of 8 or so people. So if you would move around the room, everyone can actually do this together. And I will work with this group, and we will do it together, and we'll talk about the results, right? I'll put the steps back up. But simultaneously, I would ask you as you move into these groups, to also do nominal group technique at your own table using the same question, right? So again, back to what one of the purposes here is co-production of knowledge. Again, social psychology, we're really supposed to be in the frame that everyone has something to contribute to the potential solution set that we come up with, right? So if you could organize yourselves into groups of 8, this is why I got the end of the day, so you could get up a little bit and walk around, I think. That would be great. Can we have a couple more people at table 5?
Sorry.
Sure, you want to be at table 5? With our volunteers who were coerced. Okay, so Scott, if you could write the question on the top of the page. Write the question. so let's get started. Let's choose a person at each table. So in this case, Scott is actually going to be the recorder for table 5. So people often do this in a team so that one person can be speaking and working with the group and the other person can be writing things down. So if you would choose somebody at your table who would be willing to write things down as you go around your group and talk about it, that would be really great. Right? And what we'll do is we'll call out the idea. Now put this on the top of your page. What gets in the way of screening for cognitive impairment in older people with HIV? Right, so that's the question. Every group ready if you have a recorder? Okay, so the first step is actually silent idea generation. So I'm going to set the timer on my phone. Give you 2 minutes. Just write down everything you can think of. What gets in the way of screening for cognitive impairment in older people with HIV? Silent idea generation.
So, should be totally silent so that not be
Okay, 1 more minute. Okay. All right, so as I said, I will work with this group. Scott's going to actually be the scribe at the table. But if each of you could be doing the same at your table simultaneously, that would be really helpful. So what gets in the way of screening for cognitive impairment in older people with HIV? We'll start here. Dr. Shimoy. One idea, right? One idea, one person at a time. Sarge. So limited time during appointments. So if you're the person going around the group, repeat back to the individual what you heard. Limited time during appointments. Great. Moving on to the next person. Anxiety. Great. Manpower, who will be doing the screening? You're not ready? It's okay. Mobility of the person. Right. Family support. Okay. To find a test, or actually what was said, to find the proper psychological technique. I said to find a test, that's not the same thing. Okay? Good, so now what we do is we just start over, right? And some people go in reverse because he had to wait the longest, and maybe other people's ideas were already set at that point, right? But either way, so let's go back to the top of the line here. Competing medical issues, right? Inability of the person to understand the screening questions.
Maybe resources, if we have the resources to even do this, because who will be funding, support.
Good. Resources.
I think selection of candidates.
Selection of candidates, right? Like how do you know when to screen? So selection of candidates, yeah.
Financial coverage, like insurance.
Financial coverage. No more, right? So this is normal, right? That you go around and around until all of the ideas are exhausted. Yep.
Clinicians may not want to screen for something that they don't want.
Clinicians don't want to screen for something that they don't know how to manage. Right? So if we don't ask the person or screen for them, technically we don't have to manage.
Maybe confidentiality and consent. So if there is very complicated impairment and they really get the consent of the children, that might be something.
Confidentiality and consent.
I was just thinking around, the cultural competency, whether the screening is actually, it makes sense for someone like from, let's say, in Malaysia, the some of the language makes sense, the cultural context. So I would say cultural competency and then
Cultural context?
yeah, cultural context. Yeah, whether it's culturally appropriate, those screenings. Yeah.
Cultural context.
Yeah.
Slash appropriateness.
Yeah.
I was just thinking along those lines, especially in the context of our country, where it's multiracial, multi-religious, right? I'll come back.
Maybe you say more about that. So it's like cultural context slash appropriateness, but you said I heard something slightly different.
Yeah, because in the context of a multiracial country like Malaysia, there's language barriers, and your understanding of cognitive impairment could culturally vary as well, and therefore for families to even recognize that a parent is potentially.
So we have cultural context and appropriateness, like some cultures would
species.
So for that, are we including that in that treatment?
With regards to HIV associated cognitive impairment.
I think there are some overlapping themes already from the medical.
I'll speak for myself. It definitely happens. Okay, do we have other ideas that come up? Yeah? Government support. Okay.
Sustainability maybe.
Yeah. So that's 26 ideas. Right? In 13 minutes. Right? The 26 ideas in 13 minutes that are all like quality ideas. This is the real power of non-verbal technique. So without discussion, you can move to voting. Right? If you had a limited time period, you can move to voting right away. We have the option now of discussing a bit. We can go down there. So here we have limited time during appointments. We have anxiety, manpower, right? Who's going to do the screening, mobility, family support, find proper psychological technique, competing medical issues. I know him and I can barely read his writing.
Person not understanding the question.
Person's not understanding the questions.
Resources.
Resources, selection of candidates, like how do you know who to screen, kind of thing, right? Financial coverage.
Clinicians don't want to screen patients. Confidentiality, cultural context appropriateness, language barriers, culturally divergent definitions, accessibility of facilities, stigmatization among healthcare workers towards the patient. A patient doesn't want to do the screening, not familiar with the tools. Clinicians aren't familiar with the screening tool. Taboo against mental health issues, distance, again, distance from facilities, comorbidities, cognitive impairment seen as natural in older people, denial, and government support.
Okay, any clarification needed? Anyone have questions for each other? You all feel comfortable? All right. All right, if I could have your attention for just a minute. Okay, this group just developed 26 ideas, right, in 13 minutes. So that was really rich discussion. We just clarified the ideas, and we are going to move into voting. So you should be somewhere at the point of finishing up your list of ideas, go around your group, and ask each other questions, and then we'll move into voting. Okay?
This would be the opportunity to do that, yes. If you see anything that looks like it's the same thought or idea, the person who said it is sitting right here. So you can say, these seems like these two seem the same to me, and we'll line one out. Any of that happening?
I thought about it.
There was another question.
Other,
Competing I was thinking of grouping them according to components, right?
yeah, competing medical issues and comorbidity. What you would do as a group is decide if you think that's the same thing.
It could be. Someone's kind of like your agenda is to go over certain things with the patient during a visit. And they come in and they say, oh, I started having this new pain in my knee. And, your time is not being able to get to it.
One is structural.
When I thought about comorbidities, it's being able to identify what is it that's actually contributing to as a cognitive impairment. Is it HPV or is it something else?
So comorbidities that may lead to
Yeah.
cognitive impairment.
So it's quite the same as, like you said, competing medical issues. Like, do I go for my diabetes follow-up or this?
That's a good clarification. People are clear with that, right? So comorbidities actually refers to other organ issues. But competing medical issues may be synergistic with cognitive impairment. Is that what you're saying?